Hello, and welcome back to the channel. It's your public health safe space where meaningful conversation take place. Well, today it's going to be a long one. This topic is something we have to discuss. This topic is what most people tend to want to avoid, just like they avoid the people who are suffering from this condition. Today, we're going to delve into homelessness. This is an issue that takes time to discuss with many areas to transition through. So be prepared. We're going to sit today. We're not walking, we're sitting, we're looking at nature because this topic requires our focus, our undivided attention. So today, homelessness is the topic. Thank you for being here. Remember, like, comment, share, and subscribe. Get in that comment section and let us know your opinion. Let us know if you had this experience or if you know someone with this experience who is going through it right now. Maybe the information I'll be sharing here may be helpful. Thank you so much for being here, and I look forward to your comments. So as we stated, today we're talking about homelessness. And we're not walking for this one. We're at the lake, we're having a seat, and we're going to have this discussion. Now, as I said, it's going to be lengthy, but it's important to have this discussion. It's very difficult for society to function when all are not involved. And so our homeless population is also an important part of our society, and there are issues there that we need to discuss, that need to be spoken about, that need to be advocated for. So let's begin the discussion. There are people in America today not dying because medicine has failed them, but because the system around medicine already did. A man leaves an emergency room after treatment for infected feet and steps right back into freezing air. A woman with uncontrolled diabetes is discharged with insulin, but nowhere to refrigerate it. A psychiatric patient is stabilized for the night, only to be released back into the same trauma by sunrise. A person with a worsening cough, open wounds, untreated hypertension, and nowhere safe to sleep becomes not just a patient in crisis, but a public health warning. And this is the part no one wants to say out loud. So today, the topic is homelessness, emergency medicine, and the disease risk no one wants to talk about. But this part that no one wants to say out loud is what we're discussing. When the emergency room becomes shelter, pharmacy, wound clinic, psychiatric triage, and last refuge, that is no longer just homelessness. That is public health collapse. Because homelessness is not just about housing. It's about emergency medicine, infectious disease, yes, infectious disease, chronic illness, mental health, addiction, and hospital strain. And what happens when a country waits until a human being is in visible medical collapse before deciding they finally matter? And today, I want to ask a hard question. Why are emergency rooms in America becoming the last stop for homelessness? And if other wealthy countries are handling this differently, what exactly are we refusing to learn? Because this conversation is not about politics, no. This is about systems, outcomes, evidence, disease prevention, and whether we are treating homelessness in ways that actually reduce suffering or simply manage collapse after it has already arrived. Now, the emergency room was never diagnosed to be America's homeless policy, and yet, in city after city, that is exactly what it is becoming. Not because emergency medicine is failing, oh no, but because the emergency room is often the only place left that cannot legally and ethically shut their doors. In the United States, emergency departments operate under a stabilizing duty that makes them one of the few places where a person can show up invisible crisis and still be seen. Even if they have no appointment, no insurance continuity, no phone, no transportation, no address, and no safe place to recover. And that matters. Because when people say, why do homeless patients keep ending up in the ER? The answer is often brutally simple. Because the ER is where people go when every other door has already closed. And let's be honest about what that means. A person experiencing homelessness is often not just missing shelter. They may also be missing medication storage, refrigeration, transportation, wound care, clean clothing, blood pressure monitoring, glucose monitoring, primary care follow-up, psychiatric continuity, addiction treatment, and a safe place to sleep long enough to heal. That means what looks like repeat ER use is often not misuse at all. It's a medical instability made predictable by social instability. And once you understand that, the entire conversation will change. Because a patient can be stable for discharge on paper, yes, that is possible, while still being completely unstable for real life. I want you to think about that. What does discharge mean if you have no bed, no bathroom, no clean dressings, no way to elevate swollen legs, no place to rest after pneumonia, no safe place after a psychiatric crisis, no way to keep antibiotics dry, and no possible way to recover from anything without being re-exposed to the exact conditions that made you sick in the first place? This is how the cycle begins. A person gets treated, but not truly restored. Released, but not truly recovered. Stabilized, but not truly safe. And then they come back. Not because they want to live in the emergency room. Please understand that. No. But because the emergency room has become the waiting room for every broken system America refused to fix upstream. That, my friend, is the truth. And it is why so many emergency clinicians, nurses, paramedics, and hospital teams are no longer just treating acute illness. They are treating the downstream consequences of housing instability, untreated mental health, addiction, poverty, policy fragmentation, and public health neglect. Emergency medicine can save a life today, but it cannot solve the conditions that threaten the same life tomorrow. And if we are serious about public health, we have to stop pretending that this is normal. So let's ask the question directly, shall we? Why are emergency rooms becoming shelters? Because this is not happening by accident. It is happening because several systems are failing at the same time. First, primary care has become inaccessible for many of the people who need it the most. A person without a permanent address, transportation, a reliable phone, identification, insurance stability, or medication storage often cannot move through the healthcare system the way policymakers imagine that they should. Just following up with the doctor sounds reasonable, unless you do not have one, or unless your medications were stolen, or unless your wound dressing got soaked in the rain. These are all real possibilities. Or unless your blood pressure medicine ran out 3 weeks ago and your chest pain finally forced you into triage. Second, let's think about mental health systems and their overload. Emergency rooms are increasingly receiving psychiatric crises that should have been interrupted long before the patient reached that level of collapse. People who need long-term stabilization, trauma-informed care, medication continuity, outpatient psychiatric support, community mental health, or supportive housing too often end up cycling through acute crisis settings instead. And when they are discharged back into instability, the crisis returns. Third, addiction care remains too fragmented and too difficult to access. A person with withdrawal, overdose risk, active substance abuse, or dual diagnosis crisis often reaches the ER because there is no fast, low barrier, well-connected pathway waiting upstream. And this is where people get confused. They see the emergency room crowded with visible suffering and think the emergency room is the problem. But the emergency room is never the cause. It is the collector of the fallout. Let me repeat. The emergency room is not the cause. It is the collector of the fallout. Fourth, shelters themselves are often not enough. And this is another truth people avoid. Not every shelter is safe, medically appropriate, trauma-informed, accessible, or available, or realistically usable for every person. Some people have wounds, some have severe mental illness, some are elderly, some are women fleeing violence, some fear assault, theft, instability, or separation from partners, pets, or belongings. So when people ask, why don't they just go to the shelter? The real public health answer is because a bed is not always the same thing as stability. And if the only place that is open, lit, warm, monitored, and medically responsive is the emergency department, then yes, the emergency department starts becoming shelter by default. Not because it was built for that, but because when housing fails, when mental health fails, when addiction services fail, when primary care fails, the ER inherits the patient. And that should alarm every one of us, because when a healthcare system is being used to absorb a housing crisis through emergency medicine, that means we are already operating in failure mode. Now, let's go into the part of the conversation that people are often too uncomfortable to say clearly. And I want to say this carefully. This is not about blaming vulnerable people. This is not about fear-mongering. And this is not about treating people experiencing homelessness like they are somehow less human or less deserving of dignity. In fact, it is the opposite, because public health has a responsibility to tell the truth. When large numbers of people are forced to live without stable sanitation, stable shelter, wound care, medication continuity, chronic disease management, or respiratory protection, disease risk becomes a system issue, not a moral failure, a systems issue. The CDC has been very clear that people experiencing homelessness face higher risk for both infectious and non-infectious disease, especially when people are unsheltered or living in congregate settings and face barriers of care. And that matters because this affects not just one person, but the broader public health ecosystem. Let's break that down. Let's talk about certain illnesses. First, let's take, for example, tuberculosis. Crowded living environments, delayed diagnosis, unstable follow-up, and difficulty maintaining treatment all increase public health concern around TB, exposure, and containment. Another thing to consider, respiratory disease. Congregate shelters, weather exposure, poor ventilation, delayed care, and underlying chronic illness can worsen transmission risk and outcomes for respiratory infections. Let's take a look at hepatitis C and HIV vulnerability. Injection drug use, limited access to prevention supplies, unstable follow-up, and interrupted care increase the danger of blood-borne infection. What about skin and soft tissue infections? This one is huge in emergency medicine. A blister becomes an ulcer becomes cellulitis becomes sepsis, a neglected wound becomes an hospitalization. And what should have been simple outpatient care turns into an acute medical emergency. Poor chronic disease control. This is the part the public often overlooks. A homelessness worsens outcomes, not only through infection, but through interruption. No stable diet, no medication storage, no blood sugar monitoring, no blood pressure follow-up. These are conditions that worsen. There is no sleep, no rest, no refrigeration, no routine. That means diabetes worsens, hypertension worsens, asthma worsens, heart failure worsens, psychiatric illness, yes, that worsens also. And the emergency room becomes a site where preventable deterioration finally becomes visible. And that is the larger public health lesson. Disease does not become less dangerous just because the people carrying the burden are politically inconvenient. That is not how epidemiology works. That is not how public health works. And that is not how community risk works. Because if a society normalizes untreated infection, untreated wounds, uncontrolled chronic illness, unstable respiratory exposure, and repeated collapse in large populations, it is not containing a problem, it is expanding one. So the question is not, should we care about the health of people experiencing homelessness? No. The question is already morally bankrupt. A real question is, how long can any country neglect this level of instability before the consequences become impossible to ignore? And if you ask emergency clinicians, many will tell you we are already there. Now, some people may think, so what is America getting wrong? Let's move into the harder systems analysis. Because if emergency departments are becoming shelters, if homelessness is worsening health outcomes, if preventable disease is escalating, then the next question is obvious. What is America doing wrong? And the answer is uncomfortable, as it should be. America is often very good at expensive rescue and much less consistent at preventive continuity. We are a country that often waits until a wound is infected, a psych crisis is acute, a cough is dangerous, a blood sugar is catastrophic, or a body is collapsing before we activate meaningful systems response. That, my friend, is not what prevention looks like. That is late-stage intervention. And that distinction matters because what too often happens in the United States is this. We respond to homelessness through fragmented services, disconnected agencies, episodic care, shelter bottlenecks, criminalization, short-term stabilization, and discharge loops, which means the same person can move through sidewalk, shelter, ER, psych hold, discharge encampment, police contact, and readmission without ever actually entering a stable pathway to health. And if that sounds harsh, it should, because that is not a system built for recovery. That is a system built for circulation. You cannot triage your way out of a housing crisis, and yet that is exactly what America keeps trying to do. Instead of investing at the scale needed in supportive housing, low barrier mental health care, addiction treatment, medical respite, street medicine, community stabilization, and integrated follow-up, we keep pushing visible suffering downstream into the most expensive, least preventive part of the healthcare system, the emergency room. And that creates two public health problems at once. First, it harms the person in crisis because the person is treated episodically instead of stabilized systematically. Second, it strains the entire emergency medicine ecosystem. Nurses burn out, ER physicians burn out, social workers burn out, case managers burn out. Beds get clogged, throughput slows, boarding worsens, and emergency departments become overloaded with conditions that should have been interrupted far earlier. That is not efficient medicine. That is policy debt showing up in triage. And until we call it that, we will keep pretending the ER is the problem, when the ER is often just the last institution still absorbing or trying to absorb what the rest of society abandoned. Now let's talk about government, but factually, not politically, not emotionally, not ideologically, just factually. Because if we are serious about public health, we have to ask, what has government actually changed recently on homelessness, and has it helped? There are three major shifts worth paying attention to, and we'll discuss them. 1. The federal government expanded post-pandemic homelessness and housing funding. After the pandemic exposed just how fragile housing stability really is, the federal government moved major funding through programs like OMARP, designed to support housing, shelter, and services for people who are homeless or at risk. HUD also reported that the U.S. reached more than 770,000 people experiencing homelessness on a single night in January 2024. Yes, a single night. An 18% increase from 2023. The highest recorded level since national reporting began. That statistic alone should stop people in their tracks, because it means that this is not a fringe issue. This is not a niche issue, and this is not a problem that quietly solves itself. It got worse. Now, funding matters. Of course it matters. But here is the public health truth. Funding is not the same thing as systems integration. Money helps, but if it does not translate into housing placement, case management, mental health continuity, addiction treatment, discharge support, and long-term stabilization, then the ER still stays full. And that is what many communities are still struggling with. Secondly, the Supreme Court's 2024 Grants Pass decision changed the legal landscape. In Grants Pass versus Johnson, the U.S. Supreme Court ruled that enforcement of generally applicable anti-camping ordinances does not violate the Eighth Amendment simply because a person is homeless. In practical terms, that gave cities broader legal room to fine or remove people sleeping or camping in public spaces. Now, regardless of anyone's political opinion about that, the public health question is different. The public health question is, what happens medically when visible homelessness is moved without being resolved? Give it a little thought, because a citation does not treat infection, psychosis, withdrawal, uncontrolled diabetes, chronic wounds, pregnancy risk, heart failure, or respiratory disease. A sidewalk sweep does not replace a wound clinic or respite bed, psychiatric continuity, or stable shelter. And that is the point. Criminalization can move a crisis, it cannot cure one. So, if cities are relying more heavily on enforcement, but not equally investing in health-centered pathways, then emergency departments will continue to receive the human consequences of that gap. And they already are. Thirdly, there has been a quieter but very important shift toward recognizing homelessness inside healthcare data, which is important. This one may sound less dramatic, but is incredibly important, because if hospitals and public health systems do not consistently identify homelessness in patient data, they cannot manage it well. The CDC now emphasizes homeless-related data collection because housing instability changes disease risk, access to care, and outbreak vulnerability. And Canada's health system has shown how powerful this can be when hospitals actually code and measure homelessness as a health systems issue. That matters because a system that does not measure homelessness inside healthcare will keep pretending homelessness exists outside of healthcare, and it does not. It is already inside triage, admissions, readmissions, wound care, psych services, infection control, discharge planning, and public health surveillance. So when people ask, should government change laws? Here is the most honest answer. Government policy is already shaping this crisis every single day. The real question is not whether policy matters. The real question is, are we building systems that reduce collapse or systems that simply manage collapse more aggressively? And that is the question the public health deserves to sit with. The question that public health deserves to sit with, that is it. Now, we'll say to ourselves, what is Canada showing us? Let's widen the lens. Because America is not the only wealthy country facing homelessness, but it is one of the countries most likely to force the healthcare system to absorb it in fragmented, high-cost ways. And Canada gives us a useful comparison, not because Canada has solved homelessness, it hasn't, but because Canada has done something very important. It has become more honest about what homelessness looks like inside the hospital system. According to the Canadian Institute of Health Information, nearly 30,000 hospitalizations in Canada in 2022 to 2023 included a homeless code. Those hospitalizations had an average of $16,785 compared with $7,803 for the average hospital stay nationally. Admission through the emergency department was also extremely common, 93%, and patients experiencing homelessness stayed in hospital nearly twice as long on average. That is massive, because it tells us something public health professionals already understand. Homelessness is expensive when ignored and even more expensive when treated late. And Canada's lesson is not, look how perfect another country is. No, that would be lazy. The real lesson is, when a health system measures homelessness honestly, it becomes much harder to pretend this is just somebody else's problem. And this is exactly where America still struggles. Because when homelessness is not consistently documented, it becomes easier for systems to undercount it, misunderstand it, and underbuild for it. And that means hospitals, emergency rooms, and communities keep paying the price in human suffering and system strain. Now let's talk about Europe and what Europe understands even better. And again, I want to be careful here. Europe is not utopia. Europe has homelessness, Europe has housing pressure, Europe has migration strain, Europe also has addiction and mental health challenges as well. But many European systems are more likely to start from a different premise. That homelessness is not just an individual failure. It is a failure of social protection. And that difference matters. Because once a system treats homelessness as a failure of housing access, social support, health continuity, and prevention, the response then changes. In many parts of Europe, homelessness is more likely to be connected to housing policy, social welfare systems, universal healthcare access, addiction treatment, mental health continuity, and early intervention before collapse, which means people are more likely to be approached through stabilization, support, and continuity instead of repeatedly cycling through emergency crises. And that is one of the biggest lessons America needs to hear. The difference is not just compassion. The difference is systems design. Because if one country keeps waiting until the emergency room and another country works harder to intervene before the emergency room, those two countries will not produce the same health outcomes, and neither will their hospitals. So, when we compare America to Canada and Europe, the biggest question is not who is nicer. The biggest question is who is building systems that actually reduce preventable collapse. That is the question. And right now, America still has too many places where collapse is being managed after the fact instead of prevented at the root. So you say, so what actually works? Let's end where we should always end in public health. What actually works? Because if this video only leaves people with outrage, then we have not done our job. The evidence points us toward several interventions that consistently make more sense than waiting for the ER. And let's take a look at those. First, housing first. This is one of the strongest and most repeated findings across homelessness research. The basic idea is simple. You do not make people earn stability before giving them stability. You stabilize first, then you build health from there. That means housing is not treated like a reward for perfect behavior. It is treated like the platform from which recovery, mental health stabilization, medication adherence, and healthcare continuity become more realistic. And that matters because research has found that housing first type interventions are associated with fewer emergency department visits and fewer hospitalizations based on CDC research. That is not just compassionate, that is clinically intelligent. Secondly, medical respite care. This is one of the most under-discussed solutions in America. Yes, it is. Medical respite programs give people experiencing homelessness a safe place to recover after hospitalization instead of discharging them directly back to the street or into medically unsuitable environments. Think about how much sense that makes. If a person has pneumonia, cellulitis, post-op wounds, IV antibiotics, mobility issues, or serious chronic disease needs, why would we pretend the sidewalk is a discharge plan? It isn't. And public health should say that clearly. The sidewalk is not a discharge plan. Third, street medicine. If the healthcare system cannot reliably reach people through traditional clinical structures, then part of the system has to go where the people are, where the need is greatest. Street medicine matters because it can interrupt deterioration earlier, before the wound becomes sepsis, the cough becomes a crisis, the blood pressure becomes a stroke, or the psych instability becomes a 911 call. That is prevention in motion. Embedded emergency department case management and discharge redesign is fourth. Not just discharge paperwork. An actual linkage to medications, transportation, wound supplies, follow-up appointments, mental health care, addiction treatment, housing referrals, and safer recovery pathways. Because a discharge that ignores reality is not a real discharge. It is a delayed return. Let me say it again. A discharge that ignores reality is not a real discharge. It is delayed return. 5. Low barrier mental health and addiction care. Not care that requires 10 hoops, not care that requires perfect compliance before help begins, but care that recognizes what public health already knows. People in crisis often need systems that are easier to enter, not harder. And if we build systems around idealized patients instead of real human beings, we will keep producing preventable collapse. 6. Better health surveillance and data tracking. This sounds boring, but it is not. Because if hospitals, health departments, and public health systems do not systematically identify housing instability, they cannot target resources, detect patterns, interrupt outbreaks, or build smarter prevention. And that means the same failures keep repeating invisibly until they show up loudly in the ER. So, what should we take from all of this? Here is the truth. Homelessness is not just a housing issue. It is emergency medicine, it is infectious disease, it is chronic illness, it is mental health, it is addiction, it is hospital strain, it is policy, and it is undeniably public health. And when a society waits until a person is septic, psychotic, freezing, infected, hypertensive, in withdrawal, or in respiratory distress before deciding they finally are visible, that is not a personal tragedy. That is a system indictment. Because the emergency room can stop the bleeding, but it cannot replace stable housing, preventive care, psychiatric continuity, wound recovery, medication access, or public health infrastructure. And if your emergency room is functioning like a homeless shelter, then your public health system has already failed upstream. That is the part no one wants to talk about, but it is the part we have to talk about, because the longer we pretend this is normal, the more people will continue to suffer in plain sight. And the more our healthcare systems will continue treating the consequences of neglect instead of preventing them. And that is what we need. And public health was never supposed to work that way. If this conversation matters to you, if you believe public health should tell the truth even when it is uncomfortable, and if you believe emergency medicine should not be forced to function as housing policy, then subscribe to this channel, because these are conversations too many people avoid and too many systems wait too long to face. And this video is important. So if it moved you, share it. Because some of the most dangerous public health failures in this country are the ones we've normalized. And this one is one of them. Thank you so much for tuning in. I want you to comment in the comment section. I want you to take this discussion and conversation seriously, because we are facing an homelessness concern that is broadening and expanding with every single day. The housing crisis is real. The homeless crisis is even more real. So take a breath. Your perspective is growing. Your advocacy ability is growing. Your information access is growing. And I'm here to advocate for you. So as always, like, comment, share, and subscribe. And I'll return with another topic worth discussing. Have yourself a wonderful day. Let's take a look at the ducks in the lake. Let's take a look at the view, and we'll talk soon.